There's a lot of talk on the internet about this ridiculous comment that root canals are toxic because they want to take the teeth out and put implants in. I'm very upset about this. And you know who you are. You got to stop this. So tell us the truth. Expert toxicologist, not anybody just saying things. What is the significance of root canal and real toxicity?
So the bottom line is that
everybody asks the question, is there fluoride in the water? Should I take it out of the water? Should I have rinsing with fluoride? How much fluoride? What's the answer?
One thing that no one talks about fluoride, but we know on the scientific side is that
I've been finding anecdotally that peroxide cleans the mouth if they're rinsing or not swallowing it. I find that environment is a cleaner environment. Is that true?
That is true because peroxide is a what? Free radical. So
right.
And I've been making the case that whitening actually is a therapeutic.
There's a therapeutic
There's
part
a therapeutic component that's massive, contributing to less biofilm and cleaner and more balanced biofilm.
You hear that? Whitening, bleaching kits, which are made of peroxide, will destroy bacteria and get a better microfilm on the teeth. That's a big statement.
Talking Teeth with Dr. Dean.
Welcome to Talking Teeth, episode number 9. How is everybody doing? I hope your practice is doing well. I hope you're learning a lot from our toxicology, the expert here that's going to tell us about toxicology. I hope you're doing great, and I can't wait for the summer to come. It's going to be amazing. We have with us a very special guest from Washington, D.C. This lady is so smart. I'm just so excited that she's here. Her name is Professor Claudia Cotca, and she is an MHDDS, internationally recognized research and development clinician, lecturer, healthcare provider, analyst, USA Delegate expert from the ADA. She has vast experience with global health sector in the intelligence market, healthcare policy, regulatory standards for the ADA, and subject matter, an expert witness for the USA Congress and the White House. That's very impressive. You're the smartest person I've ever met. I'm so excited to have you, Dr. Cotca. Welcome.
I'm honored. Thank you so much.
And of course, everybody say hi to Becca Mars from Concetto. House Concetto.
And she's a lot of fun. She's a lot of great time.
So we were at the big meeting, a midwinter meeting in Chicago, and I haven't seen her in a long time.
Sure.
And we just started talking, and I said, you have to be on the show. So the toxicology, tell us about what you do on a daily basis with toxicology in medicine and dentistry and how it affects our patients and how it affects our dentists.
Sure. So basically, it's a two-category process. We look at diagnostics, right? And we have to forge an impression. And then, of course, we look at the treatment planning. But the treatment planning is dependent on how you analyze the findings. And the differentiation in terms of what toxicology brings is that understanding that mechanism that is very, very essential in the diagnostic process. And it makes the point, the very crucial point, for arguing for etiologic diagnosis is as opposed to differential diagnosis, which some of our patients or consumers at large may not know, but some clinicians actually really don't go the extra mile, which we're really taught in the curriculum of practicing dentistry medicine with a license, that we actually have to meet that high-level golden standard of finding out the etiologic diagnosis. Etiologic diagnosis renders that mechanism sequence, cause and effect. And as a toxicologist, I incorporate that, I would say, analytic view, both from very specific verticals, very deep, to the more macro. So when I look at a patient from an oral systemic perspective, analyzing the elements that might come from the medical history, from a diagnostics perspective, but also from being able to scrutinize what they've been told as opposed to what they actually have.
And when you look in the mouth, when you do a first patient analysis, you look in their mouth, how do you differentiate between a patient that needs a toxicological, let's say, workup, or someone who doesn't? How would you differentiate that?
I say that I don't really, I don't differentiate between anyone because at the
so you
end,
do it for everybody?
I do, because at the end, I would think that patients appreciate having early cautionary recommendations as opposed to waiting for later to things to manifest.
Do they search out for you because of this situation? Because I haven't had a patient ask me, hey, Dr. Dean, can I have a toxicology report on my, my saliva? Right. But I do as a professional when I look at them and I say, hey, I would love to have a salivary test. I would love to have a report. How can I get that in an efficient manner to understand the biology of each patient? How can I do that as a clinician?
Sure. So your perspective, for instance, if I may, represents essentially how the entire industry and the market of services and products in the healthcare sector tracks. They really focus on just one axis aspect, a toxicology type study, or let's say a diagnostic, rendition of imaging. But the reality is that as clinicians and as scientists, we have to incorporate all the nuance of what we understand in terms of processes, and then we have to really backdrop that with respect to how the patient is presenting. So patients come to see me for second and third opinions, and that's what I really am known for, because I get to the bottom of how things develop, and also they actually enjoy very amplified synergistic treatment clinical outcomes without a lot of later interventions with respect
and
to
if you're
just
a practice that wants to deliver the white glove service and the best of the best, you have to be in the know with the science and the technology and everything digital. It's so important to combine the two and be able to provide that.
Correct. So technology exists, but it's really about how you incorporate and how you read and how you customize technology for that particular day and time for that particular patient, because tomorrow things will change.
So I find that, especially I'm teaching a lot, I've been teaching for many years. I find that the dental schools are having a tough time just getting through the procedures that they have to do. How does a dental school attack, or I guess address, the toxicology issue? Is it materials? Like, do the materials that we use are toxic, or the things that they eat are more toxic? What are you finding there?
I'm glad you actually pointed this out, because what we have to address when we address this question is really understand, first of all, how do we really understand what toxicology is?
I don't know.
I definitely
Anybody
don't.
know? I don't know. Can I find out what toxicology?
Dentist, patient,
If
I don't know.
If I can get through what is toxicology today, I'd be very happy. I feel a little smarter. So go ahead. Tell us, what is toxicology?
I'm so glad you asked. So basically, toxicology is the study and the science where you actually get to depict how things elicit a form of an adverse effect, a negative effect. At any particular
which happens
concentration.
every day, right?
Yeah, which happens continuously every day.
Right.
Whether it's a thought,
Right.
or whether it's an absolute variable that is incorporating your tissues. So we use 3 different variables that we look for in addressing a toxicity index.
Okay.
We look at the concentration, how much of the product or service or the protocol.
Okay.
We look at the modality of interaction. Is it liquid? Is it phasic?
Right.
Is it
Right.
dual? Whatever. And then we look at the time, frequency, exposure time, and recurrence
So
of the protocol.
so we got frequency, dosage, and form. Liquid.
And the form.
Okay,
exactly.
I got that. This
So
is
for
good.
instance, a varnish
Okay.
versus a liquid
Right.
fluoride, right?
Okay.
It's all going to interact
So
differently.
the first
in
thing
both
that
different
pops in my head is fluoride.
All right.
Everybody asks the question, is there fluoride in the water? Should I take it out of the water? Should I have rinsing with fluoride? How much fluoride? What's the answer?
So here's the thing. One thing that no one talks about fluoride, but we know on the scientific side, is that fluoride is a very gentle bacteriostatic.
Bacteriostatic.
Very gentle.
Gentle.
Gentle, I mean in terms of natural.
Bacteriostatic means stopping, not killing,
Yeah.
stopping the bacteria.
Yes, exactly. It's a very gentle, natural way it does that. And so if you were to look at things in terms of addressing solutions, you want something that interacts things naturally with your body.
Okay.
You may need sometimes bulldoze effect, but the more healthy the body is, it wants that preventative interaction and depends on more gentle, natural processes. So reality is that we have to recognize and accept and respect the way the cell works, the way the tissue works.
Okay.
I don't get to dictate
Right.
to my patient's profile
Right.
how it's optimally functioning. I get the opportunity to evaluate
Right.
and accentuate based on how it's optimizing.
Okay, so tell us about fluoride in the water.
So
is it
fluoride in the
good
water.
or is it bad? Let's start with water.
So fluoride, based on concentration, as it has been recommended in the water, in the commercial products, services,
Okay.
over the counter, it
Okay.
has been acclimated for the right concentration, the right frequency, and the right modality of interaction.
And it
So
hasn't changed. Has
and
it
that's-
changed in the last 5 years? Cindy?
No,
They
but-
kept it the same.
by and large, but
Okay.
I think that our consumer audience and patient audience
Right.
would like to understand some of the assumptions we scientists and clinicians already know, but they're not aware of.
Okay.
All the scientific products, services, etc., get evaluated for
Right.
the toxicity index, and they
Okay.
get evaluated for the therapeutic index.
Okay.
But the reality, what I think you're getting at with the first question is, how do I use toxicology in my assessment? I actually marry those two. I interact those two. Why? Because the science says so. My therapeutic index of positive outcome really depends on how much the body's suffering, which is the negative outcome. So when I evaluate appropriately, is the body systemically under burden? Does it need a certain layer of help, accentuation, to overcome that layer? Imagine the body has brick after brick after brick of layer of pressure. When I start to removing those layers of pressure, suddenly a threshold of response gets taken off the body, and then the body can start kicking in to some of these natural processes that are available. And what's very interesting is that when you do that, even I would say patients in the 80s and 90s, where you'd say that, well, you know, from a neurologic perspective, they've already lost mobility. They've incurred so much, you know, I would say hurdles in terms of their tremors are so excessive. When you start unraveling that layer by layer aspect that makes that mechanism really amplified, the body actually reacts, even at that later age.
So that's another question. Do you see the difference in the body reaction to toxicity, adults, young adults, midlife, and then older patients?
Correct.
Like you can have the
Yes.
same amount of input of fluoride, but is the body less to absorb it at an older age?
Well, here's one thought on that. It's not the only one, but the body's busy. The body's really busy, is busy dealing with its regular types of,
Right,
processes.
right.
But then, as much as you start adding synthetics, you start adding things that really take it, imagine you're running around Fifth Avenue constantly with like 20 kilograms of bricks in your hand every day, right?
It's going to be hard.
It's going to be hard.
Yeah.
The moment you start to remove those burdens, suddenly your muscles, your operative, your postural position changes. And therefore you're able to come and aid the clinician's treatment protocol so they can get that optimal outcome. So going back to fluoride is an appropriate requirement to acclimate modality in balance. We don't want too much, we don't want too little, especially if the individual really needs it. If the individual can brush effectively, right, at the appropriate times, which is really within 15 to 20 minutes after having something to eat or be exposed to. That's what the science says.
We're talking about toxicology with Dr. Claudia Cotca, who's an expert in this field. And we'll be right back after this message from our sponsor. Thank you.
For over 130 years, Ritter has been a name that dentists trust, delivering precision, innovation, and reliability made in Germany. Ritter implants are crafted from grade 5 titanium alloy, the strongest available. Our special sandblasting and etching process ensures superior osseointegration for lasting success. Designed for predictability and performance, Ritter implants give you the confidence to focus on what truly matters: your patients. Excellence, innovation, predictability. That's the Ritter difference. Visit ritterimplants.com to learn more.
Welcome back to Talking Teeth with Professor Claudia Cotca. She's amazing. She's so smart. And the next question we have from one of our listeners was any reports on the silver in the mouth when we're removing the silver amalgam to put in composite. What's the toxicity level there? Or if they even have amalgam in their mouth, what's the latest toxicity reports on that?
So I think it's important to understand that a lot of the concerns came really from occupational type of settings where previously there was a lot of differentiation in terms of how things were removed. But for our market in the United States and how we practice here, it's been well proven that particularly with water jet and the appropriate, hair
Suction,
remover and
yeah.
suction, it's, especially now that we use systems like Isolite and isolation properly,
Right.
it really gives us a very comfortable outline. In
And
terms of
what,
that.
what have you seen changes in the different materials that we're using in dental practice? I'm assuming the composite that we use is inert. I'm assuming, is that bad?
That's not accurate.
It's not accurate. Okay,
As
tell
a
me.
matter of fact, 15,
tell me.
20, 15 some years ago, even
Yeah.
more than that, composites, starting with sealants and
Right.
flowable, if you will,
Right.
have started to, at least in the United States market, have started to be modified to biologics. That means that it actually invokes a stimulus to the nerve, to the artery, and to the vein in the pulpal chamber,
So
in the
that's
pulpal
bad.
process. Well, yes,
That's bad.
because, for instance, this GMA, if you remember, had a lot of slack from the Europeans, as a matter
Right,
of fact.
right.
They really wanted to just do away with this GMA altogether.
Wow.
And actually, I was in the
I use that
regulatory
every day.
meeting.
I use it every day.
Well, I was in the
Sorry.
regulatory meeting at the time, and I said, listen, that's not really adequate. It's
yeah.
about utilization and where you're applying it, and what the protocol
Right,
is. So you have to
right.
justify.
Right.
And you have to say, above a certain concentration. And so the convener, of course,
So,
appropriately
so in a dental setting, if I'm putting a sealant on the bottom part of the dentin, like a dentin bonding agent, and then I put BSGME on top of that, isn't that pretty much protecting the quote-unquote nerves, arteries, and tubules?
So just on the BSGMA component, it's already been addressed. So
Okay.
companies have just gone forward, and just basically modify whatever
Okay.
they need to do
Okay.
in terms
So
of.
it's not an
just-
issue.
It's not an issue, but even if they wouldn't have modified that,
Okay.
in the aspect as I said, sometimes we have different international actors who come in with very different interests and agendas. And
Right.
basically, we have to acclimate and allow for, a range of accessibility. Sometimes, first of all, let's remind ourselves, we live on Earth, right? So it is not perfect. When we render any type of medical dental treatment, there is an incurred liability and
Sure.
there's incurred risk.
And we don't know. We don't know.
And some of it we
lot of
actually know a
things.
lot.
How about
Exactly.
acrylic?
Well, here's the thing.
Ugh,
Listen, I
no
mean,
good.
At the
I
end of
don't-
the
I
day,
don't like it.
you can't be isolated.
Ugh.
You
I
really
can't.
can't.
I can't smell
I mean,
it anymore.
when you're
it's
in
been 30
heaven,
years. I can't do it. Can't do it.
Nails.
They're still doing it in the dental schools. I'm trying to stop them. They won't listen to me.
Listen,
You can't smell that stuff.
you
Bad.
have to consider exposure, and
Right.
you have
Okay.
to consider.
There's a lot of talk on the internet about this ridiculous comment that root canals are toxic because they want to take the teeth out and put implants in. I'm very upset about this.
Oh.
And you know who you are. You got to stop this. So tell us the truth. Expert toxicologist, not anybody just saying things. What is the significance of root canal and real toxicity?
So the bottom line is that when a failed procedure has failed. When a failed procedure is either present because it has not been completed appropriately, which is appropriate infection, addressing the infection,
Right.
and appropriate filling.
Yeah.
Right. That should stimulate a healing process.
Sure.
If that
And
doesn't
it does.
occur,
It does.
Absolutely.
I
And if
have
it
8
doesn't
root
occur-
canals. They're fine.
Absolutely. If it doesn't occur, that's really when you see a deficiency.
Yeah.
And it needs a modified protocol or a modified talent and skill set on behalf of the clinical team.
Okay, but you can't just go up and start saying root canals are toxic, take them out the teeth. That's what these people are saying.
Of course.
And you know who you
No.
are. Okay, don't get me upset right now.
That's
not
something
right.
that would not be legitimate, and
Okay.
there's really no
Good.
science that
You had a question.
confirms that.
I did have a question. All right, so I know I'm really into like the gut biome and gut health and things like that. So I know there's good bacteria, bad bacteria. People drink kombucha and whatever. So I know there's a lot to be said about the oral biome as well. Is
Correct.
it very similar with bad bacteria, good bacteria? And if so, what's the best course of action to mitigate, bacteria growing in your mouth at night, during the day, and what would you recommend?
So let's discuss a few assumptions.
Okay.
So your oral bacteria is very interconnected to your gut and
Agreed.
gastric bacteria.
Agreed.
Okay.
They're almost integratable.
Wow.
Okay, and when you stimulate here, you actually stimulate, in your gastric
Makes
conduct
sense, yeah.
quite actually efficiently, depending on how healthy you are. Now, if you're not healthy and you're more medically compromised, it's going to take a little bit of time or more to acclimate that transition. In terms of eradicating bacteria, we are not that organism where we are sterile beings.
I know, this
We
is a
are
problem
a
with patients though.
symbiotic.
Patients in their mind say, I want everything sterilized, I want everything before I walk in, did you change everything? We always do anyway. But they're very conscious of it. I'm trying to tell them, you're not sterile, ever.
So let me accentuate that. As a matter of fact, we have already proven clinical cases and even abnormalities in terms of diagnostics that when certain bacteria leave the microflora presentation in the tongue, other bacteria or fungi or take over and they infect with a amplified signal where
Right,
it can
right.
take
Right, you
a
get rid of one bacteria, you're gonna
significant
increase other
amount of
bacteria.
To
time.
keep the
Yeah.
balance.
So you
Good
must keep that
Okay.
balance, and so everybody's balance is different
Right.
on a different day.
Now,
Okay, yeah,
I got
cycles,
a
especially
practical question. In my experience, you got to tell me if I'm wrong. I've been doing this for 35 years. I don't know if I'm doing it right, but I feel when the patient comes in before we start treatment, we give them a rinse of the mouthwash with a little bit of peroxide. I've been finding anecdotally that peroxide cleans the mouth if they're rinsing. We're not swallowing it, we're just rinsing for 10 minutes, 5 minutes, and then they're rinsing. I find that environment is a cleaner environment. Is that true?
That is true because peroxide is a what?
Thank God.
Free radical. So
Okay,
that
right.
and I've been making the case that whitening actually is a therapeutic.
There's a therapeutic
There's
part
a
of it.
therapeutic component that's massive, contributing to less biofilm and cleaner and more balanced biofilm.
You hear
As
that?
a matter of fact,
Whitening bleaching kits, which are made of peroxide, will destroy bacteria and get a better microfilm on the teeth.
so
That's a
basically,
big statement. It's a big statement.
So just to clarify this as well, peroxide is your end product, right? It either starts from carbamide peroxide
Right.
or H2O2,
Right.
and it basically with water, it just starts to shuffle things around, and it's a chelating effect. That means it's like we get our couture pieces, right? We don't throw them in the cycle of the laundry with their sweatpants,
But also
etc.
the gram negative.
But rather you go
Yeah.
in and you chelate and you extract those, and that process really breaks down that biofilm in a very therapeutic way,
I love it.
where
I love that.
the free
That's
radical,
awesome.
shifts things in a more
That's
natural
awesome.
way. So if it penetrates to certain layers, it stops and say, okay, I'm done. It's a natural interaction as opposed to a synthetic forced interaction,
Right.
which then has consequences from a toxicity event, and then it invokes a whole cascade that the body says, wait a minute, I'm supposed to be balanced here. I'm supposed to have this. And
Right.
the body, you have to understand, the body deals with more than 1 million processes simultaneously. You really cannot separate them like we do on the laboratory bench.
Right.
And the laboratory
That's a
bench
big problem.
studies
That's a big
have
problem.
great impact in terms of us understanding processes.
But they don't really,
But
it's not in the mouth.
But the,
in
but
vivo
the,
is the most
but the
important.
reality is that they assume and they disclose that it's a controlled study in the sense that it's an isolated one-axis drop.
Right.
It then becomes the responsibility of the clinician to use their scientific premise and understanding, to use excellence in logic, in coordinating that systematic progression of how you actually get to the presentation of where your patient is really, finding themselves that day. Because, a half an hour later, 2 weeks later,
never know.
it will be different.
Yeah. Okay, another question. This may be a long answer, but take your time.
Thank you.
How can we detect overall systemic health from salivary tests currently? What tests can we look for now or in the future?
Yeah, so there have been a lot of tests specifically done on radiation, chemotherapy, treatment cases of a variety of different cancer patients, right? But here's the important part. A lot of these salivary studies or salivary tests or salivary procedures or salivary kits have been done on more deficient qualitative and quantitative saliva.
Oh, so they did the test on patients that are already sick,
Yes,
not
absolutely.
on healthy
So it's
patients.
not a really control group.
Well, that's really where a lot of this
They
is.
need to.
I'm
They
so
need more
glad-
research there.
I'm so glad you actually brought this up
Yeah.
because majority of our research that are public
Right.
faces in terms of conclusions is actually comes from the 20% of the population
That's sick.
That's actually
Because
quite
they're,
chronic.
they're trying to help them,
Right,
heal
right.
them. People that are healthy, they're not worried
So
about us.
what happens?
Oh.
But here's the problem, Mike. What
they
happens
still have
is
to have that
they
control
take these
group.
results from these 20% chronic,
And then they
start
extrapolate
to
it for us.
extrapolate for a healthy profile, and that's when you really get in trouble.
Yeah. Right.
Because you can't have the assumption that
it's not
really
accurate.
that's
You've
what's
been
happening.
testing bad saliva,
Right.
and now you're using the same test on good saliva.
Well,
Right.
it's not as simple
not.
as
I'm trying to
this,
make
but
it
there's a-
simple. I'm trying to simplify it.
but I think you make the point in terms
The
of
point is you
how
can't
to
take.
evaluate things.
So they
and
need
how
more
to
tests on
extrapolate.
healthy people so that we can have more results for healthy people.
Yeah, but at the end of the day, we do have the opportunity. We've studied microbiology, virology, pathophysiology of disease, chemistry, physics, mathematics.
Right.
We have all that STEM foundation. Clinicians must use that on a day-to-day basis,
How do we do that?
but you decide to do it because
I
you
wanna do
already
that.
have it.
I want
You
to do
already
that.
have
You got to
it.
help me do that. I want to do that for my patients. I really want to have that test in my office. I believe there's got to be a way where we can test the patient with their saliva to
There
figure
are.
out, are they more acidic or more basic or alkaline? And then I know what cement is better for them.
Okay, so on that
I just
point,
want that.
Sure,
I
but
believe we can do that.
before you start that, first of all, you've got to categorize what bracket is your patient in. ASA 1, 2, 3, or 4.
Yes.
Then you've got to figure out which subcategory
Explain to them
are
what
they in.
ASA1 is.
So ASA1 is a healthy patient. ASA2, pregnancy is considered an ASA2.
Right.
Okay. ASA3 is basically.
What does ASA stand for?
the,
I got you.
You got me. Goodness
I'm out.
gracious.
Okay.
It's a nomenclature.
Okay.
I haven't
So
used
ASA1 is a healthy patient, ASA2 is
Yes.
pregnant patient,
It's the medical
ASA3
classification of
and
a systemic profile.
ASA3 is what? Like would be
ASA3 is basically
a
like
diabetic?
a diabetic that's uncontrolled, and
Uncontrolled.
some
And then
controlled, some
ASA4
uncontrolled.
would be a cancer patient?
Like pretty much pre-fatality.
Oh, okay.
So it's
So a cancer patient would be
bound.
ASA3?
Not necessarily, because they're
They're
cancer
healthy, right.
patients now
Right.
walking
Yeah,
around,
yeah.
depending on if
Remission,
it's controlled or not.
remission,
But
right.
the reality is that you can't, even if they are controlled, you can't assume the body really address even the last bit of it. And
Well-
with majority of conditions, you have to,
And-
be, I would say, honest and transparent about really how much cleanup is there.
But what brings to mind now is we 100% know with cancer patients who have a decreased salivary content, their saliva is not helping them, and they get more cavities.
Well, you see no more than
They
you
get more
actually.
cavities, and we see
that's
cavities
interesting.
of cancer patients. Now we got to go in there and do root caries all the time, and we're trying to
I've
figure
never
out,
think of
okay, what's
that.
the best salivary supplement? It's a whole nother thing. Is that toxic? I don't know. They're taking these supplements for salivary. Are they toxic?
Well, depends on what they are, but you see, you do actually know more science than you actually admit, because the
I do
reality is this:
anecdotally. It's my life.
when you do have a patient that has the chemotherapy, radiation setbacks, right? Your quality of saliva quantity is going to be very different, and that's really where you want to see the quantification of it.
Hmm.
Of course.
On the other hand, fluoride, varnish, calcium phosphate, different products isn't going to necessarily completely address what you're really trying to have in terms of the stimulus of the saliva. For instance, increasing VDO, dynamic and static.
That's my word.
Actually, that's your
That's
word.
all my word.
Actually
goes.
promotes saliva.
Of course it does. They're in a better physical system.
Exactly.
And their neck is all connected.
So-
now their neck is a better system. Their system's better. Their jaw's in a better position. They're much more breathing better. So you can't
So if
tell
you
me
can-
that doesn't help them.
If you
Harmony.
think so,
Does.
on a very simple note, if you can think of a duct that's basically superimposed on itself, right?
yeah.
It doesn't have,
The duct flow, yeah.
flow appropriate. When you extend it, I mean, you know,
Salivary ducts
we-
are all over your mouth. And when the body's clenched and tight, they can't have saliva. So when you open them up, they increase the salivary flow.
Well, it's either contracting neurologically, or basically releasing the particles of water
And
and
there's
components
a
out.
psychological component because
Absolutely.
they feel better. So
That's
now you have more endorphins flying around.
Correct.
It's all
So-
connected.
so you see-
I said
so
it was
you-
connected
you-
20 years ago, but now I have proof.
So you see,
have proof.
you see how this therapeutic index is
Yes.
dependent on understanding
Yes.
where deficiencies are. You
Yes.
cannot have that optimal outcome
Right.
if you don't really see where the hurdles is eliminating the opportunity for your patient to get well in a way that is amplified, in a way that they track longitudinally. And that's
Okay.
really the point.
The past 2 decades, expertise has been on 360 healthcare sector view. Why has toxicology perspective remained under the radar in the public discussion and in the dental world?
Well, there are on average, only about 9,000 of us, in the United States. So that gives us a little bit of disadvantage.
Okay.
But at the same time, it's also the market. And let me share you a little bit of understanding on this, because the consumers and I think the patients at large will greatly benefit to understand really what are the actors and what participating factors we're actually up against. The toxicology as we use it in general really gets placed in the clinical trial vertical. But that's not the only way, and we've already proven, I think, in this segment that's obvious, that you have to understand where your deficiencies are, where are your leaks, where's that corner that constantly promulgates a stimulus for the body to never clear the infection or to never clear that layer where it's always constantly on, basically on all fours in a way to have such a difficulty in terms of dealing with the normal recurrence. Imagine contractual always 24/7. The body will never acclimate to doing what it does best, lost weight during sleep or regaining, regeneration. You're extending all that interval to 2-3 times longer than it should be. So the aspect of incorporating the use of toxicology with respect to a perspective really depends on the decision of the clinician. And one area of that still uses it on a day-to-day basis is when you're dealing with infectious diseases, poisonous type of components where you have a very limited, narrow time frame, and you've got to essentially make a decision between, morbidity or, saving the patient's life. But why is our society always leaving things at the very, very last right minute, as opposed to learning lessons very early on and really taking the thread through? And I have to say that it's, for instance, Michigan, when I studied toxicology at University of Michigan, it was within the School of Medicine. It wasn't just within the School of Public Health. So that, of course, gave me an insight as to how to incorporate it more readily in the day-to-day analysis.
Do you think that people in the public health specialty in dentistry should be more vocal?
Absolutely, they should, but also clinicians
That's
should
their
be.
specialty, public health.
And also clinicians should be. And let me just say another very high pressure point. Our market for the past 2-3 decades have had a significant amount of constant promotion and stimulus to just innovate and promote R&D and just innovate, just kick out and ramp out things.
Instead of really
mastering
public
what you
health.
already have.
Instead of mastering how you actually do give clinical outcome. And let me just say this, nothing is new under the sun. Let's go a little bit more theoretical on this. Reality is that when you've hit an optimal outcome process, it stays there. However, the market wants to say, no,
we gotta move on.
We need to go ahead and
sell something else.
redo something so that we can feed in that
Follow
way.
the money.
And this is where we have a responsibility.
Question. This happens a lot. We're going to take a short break with our sponsor. Thank you very much. We'll be right back.
For over 130 years, Ritter has been a name that dentists trust, delivering precision, innovation, and reliability made in Germany. Ritter implants are crafted from grade 5 titanium alloy, the strongest available. Our special sandblasting and etching process ensures superior osseointegration for lasting success. Designed for predictability and performance, Ritter implants give you the confidence to focus on what truly matters: your patients. Excellence, innovation, predictability. That's the Ritter difference. Visit ritterimplants.com to learn more.
We're talking toxicology with Dr. Claudia Cotca, who's an expert, works for the United States government on toxicology. And of course, we have our favorite doctor, Publio Silva here, who's going to ask a couple of questions as well.
So, interesting topic, and I'm just trying to ask these type of questions to relate to patients, in addition to our doctors. What happens when we prescribe antibiotics to the patient, let's say 1 time, 2 times, 3 times in a short period of time? How does that affect the body?
It's a really great question. And by the way, I work with the USA government just to make sure that we're fully disclosed and accurate here. But 2 important things that have to be taken into consideration. One is the fact that the more exogenous outside help I give to my body, the less the body can work for itself. So basically, if you don't allow the body's navigation system to kick in and constantly be stimulated, the body's going to shut down and be like, oh, I get plenty of calcium now, I'm just not going to go ahead and produce that. Or I get plenty of this now, and I'm just going to shut that down for a moment because I got plenty of it.
Right.
And in subsequent longitudinal exposure to that, you're going to get significant modifications.
And that's why we get resistant to bacteria?
That's different. So resistance to bacteria basically is that the body acclimates to certain things and allows for the acclimation to certain things, and bacteria actually develops itself a resistance to certain things. So now that symbiotic relationship that you think you're having, you're actually not having. Not only that, but here's the kicker. It's important for me to expose myself to challenging situations, mentally, emotionally, right? But also physically. because I then test my system. A, I know what it's made of, and B, if it's deficient in some way, I'm going to now kick in with boosting of the immune system so that it conquers whatever it's up against. But you see this? The byproduct of that approach actually builds the immune system even more. And that's what I'm after. So that's why I don't necessarily go for the easy way out, the exogenous way out, meaning take things from the outside and put them in, unless they're natural, right? And the more natural the process of integration is within the body, the easier it is for the body to actually self-clean, regenerate, and the body keeps continuing and plugging along.
Is that why, I guess, the market right now is saturated with antioxidants, herbs, and all these other things because they feel it's more natural healing for the body? Is that what's going on?
Yes, but also at the same time, different sectors throughout the international, spread geoposition don't have access to our previous comment about the different composites, biologics. We are in the 7th, 8th, 9th generation of a product, whereas there are sectors across the globe where they're in the 2nd and 3rd, or even non-existing. So they have no choice. I remember when I was under the communist regime in Romania as a child, you don't have access to certain products. So you have to utilize logic and permeation of navigation. But you see, there is a God-given opportunity for optimal function. And just because it's challenging doesn't mean that immediately a frantic reaction should occur. No, there has to be an analysis of where it's really contributing to this holistic picture, not ignoring even the smallest thread, right? We notice that if we have a little speck of dust or sand, a grain in our foot, right, it's bothersome. Well, the body's the same way. I can't afford to skip even the smallest element in evaluating my patient's probability.
I love your point of view and perspective on that. And let me ask you, what's your point of view on fasting, 1 day, 2 days, intermittent fasting, 7-day fast, 40-day fast? What's your perspective on that situation?
Again, we were talking, as I mentioned earlier, it's about concentration, right, of the product, modality of interaction, and frequency and in time interval. So fasting is a wonderful way for the body to actually cleanse, your neurologics kick in, clarity of mind, etc. And to characterize the entire phenomenon that occurs into one individual over time, it's quite, quite, I would say, impressive, to say the least. However, in general, one has to appeal to that to reset things in a way, not to baseline, but just to reset things from the higher red flags. It's pulling back the body to say, hold up, break down what you've got to break down. I'm not going to overwhelm you with additional things. Get clarity, at least even the first layer of the heighten, even if you are in a skyscraper situation. But at the same time, you have to go to frequency and interval. Where a lot of the errors are done in fasting is that, again, consumers believe that, self-teaching on Google and WebMD renders a license to practice, medicine on self or dentistry on self, and that's not the case. The problem with the fasting component comes in when you actually induce what we call a the lysosomes kick in to essentially bring down the body to a
Autophagy.
Basically in position in terms of setbacks, but to a point where if the signaling and the cascades are too profound, it will not be able to stop. And that's really where then the body then kicks into a completely different set of events on the toxicity side.
I believe in, complete not eating, I think, is ridiculous. That's not what the body wants. But eating small things, small vegetables, small nuts, raisins, something that's going to be small, so you're not overloading with carbohydrates and the preservatives that we have and the meats and all the stuff that's given to us when we're having a regular meal. And the overload of that, the amount that we're eating, I think is insanity. When I go to a restaurant, I sit down, they give me so much food. You can't eat this food. I can't eat all this food.
Correct. So it is about, as I said, it's all about concentration. It's about the interval exposure. It's about how you have it.
Sugar.
Do I have it with
sugar?
Water? For instance, water. Let's talk about water.
Oh, no.
So let's talk about
We
water.
need water.
We need water.
We need water.
You need water.
What
with
kind of
every
water?
sip.
Is
We
there?
need-
How's
they're-
the
they're
pH
putting-
in the water?
they're
What about
putting-
that?
They're putting stuff in the water now.
Yeah.
Like there's stuff in the water. I don't want anything in my water. I want nothing
Depends
in my
who's
water.
putting water in your water. But
Who's
reality
putting my
is
stuff
this.
in my water?
Reality is this. I want my body to be exposed to challenging situations.
You have one more question?
Yeah, absolutely. What would be the one takeaway that you would want to leave your audience about this whole concept of, you know, the toxicology? And
One for the patient and one for the dentist.
Of course. So we're tracking likewise. So let me start with the most important, because we're here because we are here to serve our patients and the consumers at large, right? The consumers ought to remember that they have to seek expert opinion. They cannot be on their own navigating through expert situations or expert analysis when they don't even understand or are afraid or they've been made afraid of exposing themselves to the nomenclature. How are they to compare oranges and apples when they don't know that this is an orange and that's an apple?
They'll succumb to the flashy marketing, whatever.
Exactly.
it may
So
be.
romanticizing things, politicizing things still puts the pressure on experts, and this is why I'm an advocate for this. We have to share the nomenclature and terminology with the patients or consumers, no matter who they are. But at the same time, simultaneously, we have to break it down in a way that they will understand that as a non-expert. And that is the responsibility that we do carry. So on the patient side, consumer side, you must look, first of all, you have to trust your instincts. I, as a clinician, I don't know what you're feeling unless you tell me, and unless I see it, and unless I hear it, and I can, of course, see it from a result, from a test. But reality is that the sentiment and the feeling, the sensation of the patient crossing over with what the expert is checking creates a checks and balance component,
Yeah.
right? That's
That's
one. On the side of, so, and of course, finding those individuals, those experts that are willing to work together as a synergistic interdisciplinary team. And at the same time, I always tell this to patients or consumers, it must make sense. If it doesn't make sense, do not move forward. Do not take another step. It must make sense. It has to make excellent sense.
And for the dentist?
For the dentist, I would say that I'm sure all clinicians across the board, whether they're specialties in dentistry or medicine, they do practice the concept of analyzing, recognizing, and acknowledging toxic events in the process of clinical protocol. That's what happens when something happens, it's an oops in the procedure, and you say, okay, I've got to dash a little bit more twice on this thing that is doing this. Or I have to do suddenly a laser addition adjunct to amplify some signal that I really want in my clinical outcome. That's all based on things that occur during the process of attempting to heal, but there are adverse effects happening that I may not be able to quantify in a report in real time, but I can visualize, see it, and understand it from a scientific and clinical perspective. And so all clinicians do practice this aspect of evaluation. Everybody, however, in the marketplace likes to focus on the therapeutic index, but the reality is that your clinical outcome in terms of therapeutic index, in terms of positive, tangible outcome, will only depend on how equivalent and how accurate you are on defining your hurdles. If you're not realistic about the dirt, the hiccups, the red flashes, you're not going to be able to optimize what you need in order to get a maximum outcome.
Well, Dr. Claudia Cotca here. Thank you so much for being with us today.
My pleasure.
If you want to look her up, her website's www.claudiacotca, which is C-O-T-C-A. So Claudia C, C-O-T-C-A.com. Love her. She's amazing.
Thank
We're
you.
so happy to have you
Thank
here.
you so
Have a
much.
wonderful
Thank you
day.
so
We'll see you
much.
back on our next episode. Talking Teeth. Thank you so much.